Well, thank you so much, Reed, and thanks to the National Academy's team for putting together such a wonderful presentation. Thanks to presenters and to all of you. This first session, Overview and Strategic Framing, really sets the basis for our conversation. For us to be able to address important questions like, what does an equitable health tech landscape look like? And what do the different communities in the ecosystem, including developers and health systems and others, need to know to really achieve a vision for an equitable health tech landscape? That's the reason our first speaker is with us, to really help provide the background on the breadth of this digital landscape, one that certainly I'm sure each one of us has appreciated to a greater extent during this pandemic, where the digitalization has been accelerated. I think everyone also appreciates that's both created opportunities as well as revealed certain challenges. But to give us a view of the breadth of the potential for patient interactions, for the use of secondary data, for development of care plans, consumer health tools, formal health system information tools, et cetera, and the interplay of all of these elements of the health tech landscape with issues of equity, and lay the groundwork for the understanding of those social and cultural impacts of the use of these advanced digital tools in healthcare is our first speaker. Really are delighted to have with us Dr. Marzieh Ghassemi, who comes to us from the Massachusetts Institute of Technology. Dr. Ghassemi joined MIT in medical engineering and science and the Department of Electrical Engineering and Computer Science as an assistant professor in July. She came to MIT from the University of Toronto, where she was in the Department of Computer Science and Medicine. She received her PhD in computer science from MIT and MS in biomedical engineering from Oxford University as a Marshall Scholar. And she holds two bachelor's degrees in electrical engineering as well as computer science from New Mexico State University. Importantly, her research focuses on creating and applying machine learning to human health improvement, and her work has been broadly published in prestigious journals, including Lancet, JAMA, and JAMA Ethics. With that, let me thank you, Dr. Ghassemi, for joining us and enlightening us this morning.
Thank you. That was a lovely introduction. So today I'd like to talk to you a little bit about how I think we can try to do more healthy machine learning in health by using AI to perhaps become more fair, or the fairest of them all. Next slide. So machine learning, I think it's important to recognize, is not a new thing in medicine. Meaning, if we take machine learning sort of defined broadly as algorithms or models that have thresholds that we can calculate and then make decisions based on, those kinds of models have been present, especially in acute care, for decades at this point. Next slide. The issue is that now we have these models, and every one of these lines is a model that was trained in an academic paper. And they're performing state of the art, as what we call it in machine learning, at or above human performance. This is across the range of the human lifespan. All of these tasks, like in-hospital mortality, disease onset, suicide, delirium, readmission, sepsis. And so the conversation has really changed in tone recently. Next. But along with this change in tone, where we're suddenly thinking, wow, we can all train these really advanced high capacity models that can be very helpful for us. There's been a corresponding conversation about, well, but what are those models actually doing, or what's inside those boxes? Next. And specifically, there's a lot of focus on, do we trust these models? Next. So my group focuses on creating actionable insights in human health. We target learning what models are healthy. This is a more technical kind of model exploration. What kind of healthcare is healthy? How might you deploy these things? And then what behaviors are healthy? How do we make sure humans use them appropriately? And next, in this first part, I'm going to talk to you about a technical exploration we did that motivated some deep ethical introspection. So next. Privacy is a big concern in clinical prediction models. Why is it a big concern? Because even if you have anonymized data, it's still not robust to a linkage attack where I have, for instance, redacted information on the left in a medical record, but the same kind of information is present in a public record, and that public record identifies you as an individual. Next, even worse, if you are a relatively unique individual, for example, Sumana, shown on the left, might be the only person of her gender, race, and age in her zip code. And so minority patients, for instance, might just be more uniquely identifiable. And so the current state-of-the-art technical approach to ensuring privacy for individuals who might be relatively unique in a data set is called differential privacy. And so this was used in the US Census, Apple and Google use it, and it's a way of ensuring that an adversary who has access to the data or the outputs of a trained model cannot identify individuals who might be more uniquely identifiable based on attributes that are available. Next. So let's take one of those tasks that was in that nice paper, list that we had on a prior slide, mortality prediction. And we took data from a local hospital and we decided to train it in a way that it might actually be deployed in real life. What I mean by that is we're going to train it every year, only looking at data from prior years. And then we're going to test it to see how well it predicts data in a new year. So for example, the performance in 2008 is how well a model trained on data from 2002 to 2007 does on testing unseen data in 2008. And the way that we ensure differential privacy in one of these neural network models is we train it the way we normally would by sampling some data, learning a gradient, and taking a step in that gradient direction for the model. But if there's a relatively rare data point, it pulls the gradient around, and that's what makes that data point or the output of the model uniquely identifiable. So anytime there's too much pull by a specific data point, we noise it and we clip it, this gradient. And so now we have this sort of smooth, differentially private version of a neural network. Next, unfortunately, while this is not true in other domains, like in computer vision, for example, when we impose differential privacy in a healthcare setting, there's an extreme utility trade-off. So this is work published earlier this year where we found that you're seeing performance drops from these state-of-the-art numbers that were reported in other work and in our work as well of between 0.85 to 0.9 for neural network models like a gated recurrent unit neural network, all the way down from the red line to the blue lines to no better than chance almost at a level of 0.5. And so this kind of trade-off really is very extreme. And next, even worse, who's really being affected by this, this technical model are the minority patients. And so we found training data loses its predictive influence on test data with more privacy. But some patients lose more influence than others. And what we found in our data set specifically is that adding privacy changes the most helpful group in the training data from Black patients to white patients for the Black testing patients. And so it's really, machine learning in general is built on finding and enforcing similarity. And if you are saying that any point that is too unique needs to have its input clipped and noised, you're really limiting the effect that minority patients can have on machine learning models. Next. And so this really caused us to think about how might we deploy models like this in a healthcare setting. Next, because unfortunately, bias is part of the clinical landscape. All right, so humans are biased, which means that doctors are humans, so they are also biased. And so clinical care reflects the biases of society. Next. And what we did most recently in a paper that'll appear, I think later this year in Nature Medicine, is we tried to establish what would happen if we took a very simple case. So you've probably seen many examples of chest X-ray diagnoses. So we took 3 large chest X-ray data sets, 700,000 images. Next. We trained a DenseNet, it's a kind of convolutional neural network, to predict no finding meaning the model says the patient is healthy. You can imagine using this in a triage situation. Next. And then we compared the false positive rate, which you can think about as underdiagnosis, because next, a false positive for no finding, for example, in one subpopulation, if it was higher for female patients, would mean if you deployed this model, there would be a higher rate of no treatment for these patients if the model were deployed, even though they actually need treatment. Next. So what we found is that in unseen test patients, the model, the state-of-the-art model that's performing at or above what others in the field have been able to get on chest X-ray diagnoses, had a larger underdiagnosis rate in females, next, in younger patients, next, and Black patients, and those that are on Medicaid or uninsured. And next, the unfortunate fact is that it's even worse for intersectional identities. And so the underdiagnosis of this model in unseen test patients is worse, for example, for Black or Hispanic female patients than for white female patients. Next. And you might say, oh, it's good that you audited that model, that you made sure. As in other work that I've done in my lab, why don't you just make sure that everybody audits their models? That we have a set of identities and intersectional identities that are, well-defined, and you have to show some threshold of variation performance that you do not exceed. And so here, if we're predicting mortality using ICU notes or psychiatric notes, you have to show me that based on ethnicity, insurance type, or gender, there's not a significant difference. Unfortunately, next, when we're dealing with high capacity models and real clinical data, this bias can be very pernicious, and it's hard to understand how it might impact model performance. So when we trained a contextual language model using PubMed embeddings, so this is a publicly available model called Cybert, and then asked it to fill in the blank, which is a common task. This happens in mental health chatbots, or people use it now for sentence or note completion. We asked it to fill in race, patient became belligerent and violent, sent to token. Next, when we tell it that the patient is Caucasian or white, it fills in the blank with hospital. Next, when we tell it that the patient is African, African-American, or Black, it tells us that the sentence should be completed with prison. This is not something that you could easily identify and easily audit. It's very deeply buried. We had to work hard to find this, and it's hard to remove it from the model. Next. So I think what this means is that we need to acknowledge that complex health systems generate complex health data. It's not just about biology. This is about a system that is generating the data. And so we need to be careful about how we use the data. Next. And you might be asking, well, how much bias could there be? So I'll talk through one final. We were inspired by this economics experiment from 2013 that found that eBay auctions for iPods, where you only varied the color of the hand holding the iPod, the ad is the same, everything is the same, had white hands receiving 21% more offers than Black hands, which is irrational. There's no reason that this should be happening. Next. So we looked at what would happen if we provided advice to clinicians and said it was from an AI versus saying it was from a human. It's the same advice. It's the same x-rays. Okay, so we varied two things. We varied whether we said the advice was from an AI or a human, and we varied whether the advice was correct, accurate, or incorrect, inaccurate. And then we asked people, what do you think about the quality of this advice? And then also, what is your final diagnosis? And then we evaluated two kinds of doctors, radiologists who are experts and IM/EM doctors who see chest x-rays, but it's not their expertise. Next, we found two things. Number one, experts tended to rate AI advice as much lower, statistically significantly lower than human advice, even though it's the same advice. But despite rating the advice as lower, they failed to dismiss incorrect advice just as often. So whereas experts are better at the task than non-experts, they are not better at dismissing wrong advice. Next slide. Seen another way, While experts generally have better diagnostic accuracy, so every one of these vertical bars is a radiologist on the top or an IMEM doctor on the bottom. Next slide. We have a similar number of susceptible clinicians who anchor to incorrect advice despite saying that they trust it less. Next slide. And so I think what this means is that we have to create actionable insights in human health by looking at behavior. Next slide. There's no simple fix for ethical ML in health. It's an ongoing process that requires improvement and requires engagement on many levels by diverse teams. So there's a review that we put out recently on ethical machine learning in healthcare. It's one of the annual reviews in biomedical data science. And next, I'm going to talk very briefly about data collection for a moment, because I think that's something that is topical and also potentially addressable. Next. So within data collection, some of the things that are open issues for community discussion are, we know there's heterogeneous data losses. So data loss by data type. So for instance, we know that losses can impact populations differently for each of these different kinds of data. In the United States, uninsured Black and Hispanic patients are less likely to have primary care providers with EHR systems as compared to white patients with private insurance. And so when we download and use EHR data sets, there's an overrepresentation of some kinds of patients. Next, there's also differences in population-specific data losses. So historically underserved groups can be underrepresented or just missing. So we know that autism diagnoses for Hispanic children in California fell following aggressive federal anti-immigration policies because there was a fear of going into, we assume there was a fear of going into clinical offices for these diagnoses. And then when present, it's often true that these disadvantaged communities are just less likely to be accurately captured, the nuance of their information in data. So documented sex is often discordant with gender identity for transgender and gender nonconforming people. Next. And finally, we have to be very thoughtful when we're widening the data ecosystem, that we're just not widening the data gap. So if we think about understudied areas like women's health, there's this big push to use ambulatory health tracking mobile app because these crowdsourcing efforts could accelerate research. We could have cohorts that are orders of magnitude larger than those used in previous studies, but these small choices can create problematic data gaps that will leak into human and model learning. We know that data from online app platforms consists of people who have access to the internet. And if we limit samples, for instance, to desktop or mobile platforms in non-North American contexts, that can exclude populations and be very problematic. Next. And so I really want to push for the availability of embodied data. I'm a big proponent for allowing the academic community, the public research community, to have the same kinds of access to health data that private companies are able to purchase right now. Because if we want robust, private, and fair, high-quality algorithms, it requires large-scale, diverse data sets. Next. And we know that health currently lacks machine learning fields in reproducibility. So other fields like vision and natural language processing tend to have more released code, and they tend to have more released data. And they also tend to ensure that papers that are published leverage multiple data sets. Next. And there's two quick things I want to say on the technical side that I won't linger on. Synthetic data is not a robust solution. You can't just take data and say, well, it's too hard for me to have data usage agreements and collect ethical usage forms. I really need to do synthetic data. That doesn't work out, because if you supplement or replace data sets with synthetic data, it's still biased by the underlying imbalances in original data. Next. And post hoc balancing doesn't work either. So if you start with biased data at the onset of a machine learning model to learn a representation, balancing later on also doesn't fix it. Next. And so I'll close with saying, I think we've addressed the tip of the AI iceberg. We really need to address issues that lie really far under the waterline that will require introspection. Next. And this is going to require transparent data, models, and processes. So as a community, we need to focus on these issues. Thank you.
let me thank you for an absolutely brilliant presentation. I take away a number of points that are really a number of conundra. These are complex systems, they produce complex data. And the results, the examples you showed are really sobering. Conundrum number one is that these are high capacity models, and as you noted, in many areas, they're outperforming humans. At the same time, you've identified, fundamentally these challenges, and particularly in terms of an equity lens. On the one hand, minority patients may be more identifiable by virtue of minority status. At the same time, the tools like differential privacy, individuals who may be underrepresented lose influence in the model. And so here are a number of conundra, and we have a number of questions that have come in that are sort of on this theme. So let me just read the first one here is that we all believe in the need for privacy and how data can challenge that. However, as a clinician, sometimes knowing certain data is necessary. How do we find the balance? What advice do you have on perhaps that clinical community?
I think we need to understand that privacy should be mitigated by the need for knowing the data. So I don't mind that my clinician has access to my medical record. It's something that I and all patients consent to because we want to receive the best care. I think, part of the tension, I think, at least in the United States with privacy is the fact that we know that our data can be de-identified and sold to private companies that may have access to other data about us, and it can be joined, right? Maybe there are ethical or moral obligations not to, but the technical potential is there. And so I think as a researcher, I am also very comfortable with my de-identified data being released as part of a data set to other researchers who are trying to understand the risk for Western Asian women developing gestational diabetes. Because I believe in that cause, I think it's very worthy. I think that that's something we need to do as a research community. And while I think a publicly funded researcher could also potentially technically acquire some other data set and perhaps join it, the incentive isn't there, right? It's just not the same. And so I think we need to condition our requirements for privacy on what the context and use of the data is.
That's terrific. You mentioned the need for embodied data, not just synthetic, but you just drew a limit in terms of the breadth of embodiment, if you will, by saying, okay, research community, fine, extension to a commercial interest, perhaps not. Is the line use case dependent, or is it protean?
I personally think it's use case dependent. I am, as a consumer, I am much more comfortable with the idea of public research being done for public good to advance science with a wide variety of very detailed data that I produce as an individual, my embodied data. I am much less comfortable with that data being used to sell a product. And so it's I think a personal line, and it's navigating this really tricky issue of consent and whether we as people really understand what we're consenting to when we have data that's available.
Well, the next question actually challenges one of those use cases or provides one real world example. The individual asks, I would like to understand the relationship between algorithms, AI, and the practical application of crisis standards of care. All of us at the front lines of care, obviously, in COVID, are faced with this as a live issue.
I think it depends on the task and the use case. So what I mean by that is algorithms are sets of instructions that you can hard code essentially if you want to. But machine learning or AI, a distinction in my mind is you don't hard code things. You say learn what that threshold should be based on the data that you observe, right? And the tricky nuance with that is it's going to learn what you do, not what you say you do. It's going to learn that you spend more time with white patients in the ICU, not that you say you should spend an equal number with all patients. And so I think when we're talking about crisis management, we need to have some introspection here and say, it's not that the models are bad or evil, it's that it's learning what we actually do, not what we say we want to do. And so we have to be very careful about in crisis management. Are there things we want models, for example, if they're automating bed allocation, are there things we don't want them to learn about how things work in practice?
Yeah, great point. One of my big fears is that ML and AI not only recapitulate, but can amplify some of those adverse behaviors. So there's a great comment in chat here. Shouldn't we start with an ethical framework that we can agree with as prelude to all of the more practical applications? Do we need that horse before the cart, if you will?
I think an ethical framework would be, is that there are many is the issue, right? And so I was recently debating this with a colleague where we had a paper that where the reviewer said, we had written a line where we said, you need to be very careful about ethics and machine learning for health because you don't want to do harm. And they had responded back rather snarkily saying, well, this is already a principle in medicine of do no harm, right? It's already there. The ethics are there. And we said, yes, but there's what you say and there's what you do. And so I think we need to have a much more detailed, it's a very hard conversation to ask a doctor, to ask a hospital, when I find in your data that you are actually doing A, even though you would potentially be uncomfortable with a model doing A, what would you like me to do with that?
Great points. Now, there are two questions that move to the practical application. Part is the size of the data pool in terms of identifiability. Does federated learning or shared analytic capacity help?
So federated learning, I think, works well in situations where you have a very good understanding of the underlying data generating function and the distributions you're investigating. I don't think it works well in most healthcare settings because we're often dealing with different hospital systems, which may have different underlying distributions of data, patients, even the variables they collect. It's very challenging to make models work well in a federated learning setting in health specifically. In terms of getting additional data to try to increase the number of individuals that we report on, yes, I think that adding more individuals by data sharing or some kind of pooling makes a lot of sense. But there are people who are just minorities. They are relatively unique. And we, I think, should acknowledge that pooling won't help them. We need to move in machine learning on the algorithmic side from saying, find the pattern, find the average, remove the outliers. That works for computer vision. Noise is an outlier, but in health, that's a person, right? If a person looks like an outlier, they're still a person. You can't just clip them from your data set.
Okay, so recognizing that you have, and you've been absolutely fabulous, have a hard stop about 10 minutes before the hour. There are two final questions. One gets at this ethical issue is that, okay, so you commit to an ethical framework or choice of ethical frameworks, but what about the embedded values in patient consent or disagreement? How are cultural variations captured in that? Another permutation that a consequentialist ethics would favor the individual and their privacy, while a communitarian ethics focus would be on what can be learned.
I think that the best way to think about, and I think about this quite a bit actually, on the second point is if you have a model, for example, there was a lovely paper that came out from a colleague recently at DeepMind on acute kidney injury prediction, and they used VA data. And there's a note in there, and they predict it really well. It's wonderful. Acute kidney injury is a big problem. And there's a note in there that I think they had, maybe 5% of the data set is female. That's the data that they have, right? But you could imagine, and so the question one of the reviewers had asked is, well, could this work in women? I told them I don't think so, because it's not actually learning these dynamics in a diverse population. And so you could imagine that if all Western Asian women, I'm picking on my own group here, said, we refuse to be included in your diabetes models, privacy reasons, that's fine. What that means is, if a diabetes model is used to optimize your care, it will not work well for you. That's what we have right now, by the way, right? We have models. There was a a really lovely paper that came out recently about rethinking race and how we use race in models, right? And it pointed out that if you use a self-reported race in many of the current standard risk models, it either overestimates or underestimates your risk. And it's probably because the population that was used to estimate those risk scores was incredibly biased from the start. And so I think communities need to make decisions, but there should also be it should be clear that there is a strong incentive and there's a strong public, institutional responsibility to protect that data and what happens to that data once you give the data up into this system.
Fantastic answer. Okay. Final question, very briefly. You heard Dr. McGinnis tee things up that part of the goal is a learning health system that implies secondary uses of data. Our team are involved with trying to accelerate the understanding and treatment of COVID. So there are pressing societal problems. There are shortcomings in health and care. So here's your opportunity. If you could snap your fingers and make things happen, how would you reconcile this? What would be the sort of sketch, the architecture of the system that would allow for learning healthcare and learning health?
If I could snap my fingers, I would have a holistic health care system that feeds data into a publicly funded and guarded entity that allows all validated researchers to have access to that data as long as they pass an ethics review that is manned by a diverse set of stakeholders. Because right now, we're really scratching at the surface. And, people always ask me, why do all you machine learning people predict mortality in the ICU? We are looking where the light is shining. We either cannot get access to other data or that data doesn't exist. It's not that we can't get access to it. It just doesn't exist. And unfortunately, a lot of this data does exist. It's just in the hand of private entities or honestly public entities that have no requirement to share their data with other researchers. And I think that's the biggest travesty in my mind. We have all of this data that exists in hospitals, in healthcare systems that in our country. And publicly funded researchers don't have access because people are keeping it locked up. They think they're sitting on gold, and so they won't give it to the greater good.
Well, thank you very much for that inspiring vision. It's a great kickoff for our conversations. And Dr. Qasimi, that was just terrific. Let me at this juncture turn over to Bill Novelli and Dr. Reed Tuckson to facilitate the next session on ensuring equity in AI. Thanks.